Rabbi Adras, thank you so much. I know another word for love, it's palliative care. And if any of you are interested in a really important series of papers, I'm sure Diane Meyer can speak about them, about exactly what Rabbi Adras was discussing, which is that when people are surrounded by true care, sometimes they actually live longer, which is astonishing and beautiful. It's now my intense pleasure to introduce Elliot Fisher. I met Elliot more than a decade ago. I was working on a story on overtreatment for the Atlantic magazine. And what struck me and what I remember about meeting Elliot was his generosity with his time and his intense desire to help me understand the pervasive nature of the problem of overuse. Fair disclosure, I've been an instructor at Dartmouth, but I really think, unbiased here, I think it's scurrilous that anyone would say that conflict of interest is at work. That the work that Dartmouth has done, that Elliot and others at Dartmouth have done and still do, has illuminated this problem more than almost anything I can think of. Elliot is the director of the Dartmouth Institute of Health Policy and Clinical Practice and co-director of the Dartmouth Atlas of Healthcare. He's made huge contributions to our understanding of the problem of overuse and of geographic variation in healthcare. And if you only read one paper from Dartmouth, let it be Avoiding the Unintended Consequences of Growth in Medical Care. How might it be worse? It was written in 1999 with Gil Welch, and it appeared in the Journal of the American Medical Association. Elliot, it's a true privilege to have you at this meeting.
Oh, what an amazing treat to be here with so many friends. And after this wonderful morning's welcome about thinking about why we're here, what is our purpose. We're going to have a panel this morning. I will maybe now ask our panelists to join me up here. I'll do a little bit of introductions and then I'll set it up if I could. So we are here. I see Brent, Reverend Stanfield, are you somewhere over here? Welcome. Come on up and join us here. Patrick, you're here. I saw Brent. Joanne, I saw you earlier. There you are. Mark? Wonderful. Who's missing? Patrick, Mark, Joanne, Burns, Dick. Welcome. Nice to meet you. So we will, just to set this up a little bit further, I'll introduce them briefly, although you know something there. We will do about an hour and 15 minutes on the before we take a break, and then we'll come back. We'll have plenty of chance to both hear from our amazing panelists, but also to hear from you. And I'll come to that in a second. So, do you guys happen to be sitting in the order here? Probably not. No. Well, I can. So, Bern Stanfield is the president of the Greater Boston Interfaith Organization. He's been the pastor of the Fourth Presbyterian Church in South Boston for the past 20 years. I've been at Dartmouth for 27, so, stodgy old. Brent, how long have you been in Intermountain? We won't date ourselves by going any further down that. Dick, where are you? Dick, welcome. Dick Jackson. He's done a lot of work on the impact of the environment on health, which as we start to talk about this morning's panel, the purpose of this morning's panel, which is sort of the reintegration of health and healthcare, it's going to be really important to have that perspective. Mark here is currently the national coordinator of the labor campaign for single-payer healthcare. How many people from Vermont here? Yes. So there are a few single-payer residents of a place that may someday be a single-payer state. Here, Joanne Lynn, who many of you will know, is the director of Altarum's Institute Center on Elder Care and Advanced Illness, focusing on coaching communities to build locally excellent care systems for frail and chronically ill patients. Brent James is at Intermountain Healthcare, executive director for their Institute for Healthcare Delivery Research, and Patrick Lee is medical director of the Primary Care Center at Cambridge Health Alliance and an instructor at Harvard. So why are we here? It was a wonderful wonderful frame. What is our purpose? Let me try to get to that through a story. Our purpose is to talk about what should the future of healthcare be like. What do we envision it being like in 25 years? And the reason I think vision of a better future was brought home to me by an experience I had a few months ago. The people who set the regulatory requirements for healthcare facilities, the Facilities Guideline Institute, who cause these things to be overly built, incredibly expensive, palaces that are the opposite of stewardship, that cost our communities dearly. That group, the Facilities Guideline Institute, decided to do a visioning session about what should the future of healthcare look like, or what might the future of healthcare look like in a way that would inform our development of future guidelines. They used to do their guidelines, they do their guidelines every 4 years, and they usually add another couple thousand pages to the regulatory guidance, which then states use to design the buildings that we're all stuck with, single room occupancy, because it's, quote, safer, art on the walls, et cetera. So this was organized by the FGI. Kurt Rockstroh is the chair of the Facilities Guideline Institute. And we had an amazing morning envisioning a future for healthcare with the leadership of the Facilities Guideline Institute there. And at the end of it, Kurt stood up, tears streaming down his face, and said, we have to completely redesign the way we think about our buildings so that the built environment meets the needs of people and communities in ways that are stewards of our community's future. And Lord knows what we'll see of it, but they're moving away from every 4 years. They're going to try to every 4 years reviews. They're going to try to get back to a much more efficient, parsimonious, thoughtful, community-focused, creative, flexible way of designing buildings. So that's why we're here. This is an amazing group of people, both here, the panelists who can help us think about this and are going to start the conversation. But if we can come up with a great vision for what the future of healthcare could look like 25 years from now, we could all walk out of here in 2.5 hours, maybe empowered to do some new work, maybe thinking differently about how we will do the work we do at home. So I think we have a really, really important window of opportunity here with starting this discussion about what should it look like. And with that, why don't we, let our panelists launch into what you think it should look like. And we'll just go this way through. And if you go for more than 8 minutes or something like that, dial it back down. Otherwise, they're going to take the whole time. So 8 minutes. I'm sorry? Yes. Oh, absolutely. We're going to be framed by Vikas, right? You have some slides for us? Okie doke. Thank you.
Thank you, Elliot.
Sorry. No, exactly.
But I just wanted to add a little bit of background in terms of how we got here for this panel. After the last conference, we were talking to a number of us and had a roundtable visioning session. And I thought, we're all pretty like-minded, and this is not going to, how interesting or controversial could this be? It'll be very fast. And in fact, it was lively, energetic, really inspiring, and everyone around the table said, you got to do this at the conference. And so if people who have the documents could distribute them. So there are 2 documents we want to share with you as the panel starts, and I'm not going to take much more time, but one of them is really kind of random staccato statements and thoughts that came out of that first exercise. And the second is actually some work Shannon and I have been doing, and actually doing with Dick Jackson on the panel, thinking about this as a strategy, as a grand strategy, as something that all of healthcare really can and should think about, envision, and then embrace. So the second document is, it's titled Grand Strategy. So please have a look, and what we'd love to do is get feedback from everyone, from the panel and others, about that. And then the last thing I'll say is that I think we were very lucky yesterday that the elements started to peek through things started to peek through of what that system would look like. And I think, we could talk at length, and I'm sure the panel will. How do you put primary care right at the center? How do you really shift resources from hospitals to communities? How do you manage this transition, which is a transition fraught with dislocation? And how do we address what in the health world is called the social determinants? But you know what? It's really about, maldistribution of resources, lack of early childhood education, lack of decent road, you get the drill. So it's a big topic and a big question, but we really wanted all of you to think with us about this and all of us to start engaging in this process, because I think the outcome, as Elliot said, not just in the next 2.5 hours, but over the next period of time, could be very consequential.
Oh, Vikas, thank you. Sorry I'd lost my script. So others of you should feel free to interrupt and correct me as I go along. Why don't we start with panel members giving us, a few minutes of your thoughts, and then we'll open it up to a broader discussion. And do you want us to do it from sitting down? You have a mic on, so you can do it from sitting down.
Sure, I can do it from sitting down. Again, I'm Bern Stanfield, and as I imagine a healthcare system, an idealized healthcare system 25 years from now, if in this sea of medical people, let me say who I am. A couple things. I'm a pastor. I'm a Presbyterian pastor a few miles from here at Fourth Presbyterian Church, next to a couple of housing projects in South Boston, with a wonderful congregation that I love, and I've been there 22 years. I'm also an organizer. Our church is a founding member of a group called the Greater Boston Interfaith Organization. We've been involved for 15 years. I'm now president of that organization. That group is engaged in broad-based community organizing. We are interfaith, Christian, Jewish, Muslim, and we're about building power and identifying issues on which we can act in the public sphere. And a big part of that has been healthcare. Several years ago, we were very involved in the Massachusetts campaign for healthcare access, and in the last few years, we've been working on cost containment. Third thing I need to say is I'm a spouse, and in particular, not working? Okay. In particular, my wife is a primary care physician at a neighborhood health center in Dorchester. She's been there as long as I've been at the church. She also teaches at BU School of Medicine. And a year ago, she was diagnosed with breast cancer. So we've been on that journey for the last year of surgery and radiation and chemotherapy. So that informs these three things I'm going to identify in my 5 minutes remaining here. Three things. One piece that I imagine and hope for is really, really good communication. And I mean electronically and relationally. I asked my wife this question, what would she like? And she said what she would love to do is that when a new patient comes, and they come, every 8.5 minutes or whatever it is in her health center, if she knows that this person has had tests in different places, she wishes she could see the results. That's not the case right now for her. And it's incredibly frustrating and wasteful. So electronically, better communication, and of course relationally. In my congregation, we're having some conversations right now about end-of-life care. What do you want? Have you talked to loved ones? We're working with Ellen Goodman's project, the Conversation Project, which some of you may have heard about. And a man named David told this story. He was with his beloved aunt, who was like a second mother to him, in a care facility, and she'd been doing okay, except she was just diagnosed with pancreatic cancer. Old enough, it didn't look good. And the doctor and a nurse were there asking Aunt Audrey, what would you like for your care? And her response, according to David, was, I want the whole enchilada. Everything you can do to keep me alive. And then they proceeded to discuss what the ingredients were of the whole enchilada. And she said, I don't want that. No, not that. Maybe this, but no, not that. And it was not aggressive care. but it was beautiful care. And David described how his devoted Catholic aunt was in this Catholic nursing home, and he, the Protestant, would bring his Protestant hymnal in there and sing hymns to her every visit. She loved it, he loved it, and I think even the nuns around there loved it. It was good care, and it was good communication. Second piece, I would say, so really good communication. Second piece I envision is engaged citizenry. I'm intentionally using political language. I'm in organizing not only because I think it works on particular issues, healthcare and otherwise. I'm also in organizing because I'm passionate about democracy working. And I don't think that's a foregone conclusion. People need to be engaged. We build power a relationship at a time within our congregations so that we can work together and hold politicians accountable. I think caring for one another is part of our life together as a society. For that to work well, we need to be engaged as members of that society. So I'm talking about politics. Our involvement in recent years in GBIO has been cost issues. So we met this past summer with CEOs of insurance companies and the biggest hospital systems. And we were able to bring them in one room in a temple, in a synagogue this fall. And the biggest thing was seeing each other, being with each other, knowing there's an accountability. Okay? There's a temptation in our country to assume the market fixes it. Theologically speaking, the market is the God. As a pastor, I have a problem with that. So we need to be involved as citizens. Third piece, I would say, and it sounds simple, to truly share in supporting the sick. This is a core value, and I hope we don't lose sight of that core value. In doing our research on cost issues in GBIO, what we realized, of course, and this is no surprise to people here, is that as healthcare has gotten more expensive and insurance plans get more expensive, people try to get by financially by getting coverage, and I'm talking about individuals and employers, getting plans that cover less or more significantly have higher deductibles, which is fine until you get sick, which means the burden of financial risk is going to the sick. And that strikes against a core value of my faith tradition, and I would suggest all faith traditions. The biblical language in my tradition is widows and orphans, those most vulnerable. That we heard another phrase yesterday, the classless fraternity of the stricken. I mean, this is the core value. Are we together? That's how you measure a nation and a society. When my wife got sick a year ago, it was really scary. And part of that was we're facing mortality. She's actually doing very well, let me say. She's doing well right now. But the second part of that scariness, even though we have two good jobs and I have a decent plan, I eventually figured out I didn't know any better when we were diagnosed. I can't tell. But it was scary financially. It was really, really scary. So I suspect there'll be conversation about single payer, et cetera, whatever it is. Bottom line, when somebody is sick, I want the community, the society, the nation to be with them. That goes to the values in my tradition and others. I'm preaching now, so I'll stop and let it go there. Thank you.
Wow. A good Presbyterian.
Yes.
Given the STEM one, Derek.
You want to go just?
Yeah, let's just go. Let's just work.
Hey, well, good morning, everybody. My name is Mark Dudzik. I'm with the Labor Campaign for Single Payer. I've spent pretty much my whole life in the labor movement as an organizer and an activist, and I'm really glad to be here because it kind of gets me out of the silos that I spend most of my time in, so I'm excited about learning some new things and grasping some new ideas. So our vision, should be no surprise, is, in less than, 25 years is this window? Much less than 25 years, that healthcare will be seen and treated as a fundamental and inalienable human right of everybody in this country. Why it isn't in this country is really, it's rooted in the past, and I want to talk a little bit about the past and the role of labor in that, just to put some perspective to where we are. Really, in general in this country, health care is seen not as a human right, but as a benefit attached to employment. And there's a series of sort of historical accidents, mostly in the 1940s and the early 1950s, that kind of put us into this system, I would say trapped us in this current system of healthcare provision. And I could certainly go on length about a lot of these concerns, but it has to do with competition for labor during World War II and the ability to provide benefits to recruit labor, and then with subsequent decisions that people who came before me in the labor movement made in negotiations. There was something that's kind of the shorthand is the Treaty of Detroit, an accommodation that was reached in the late 1940s between a growing and vibrant labor movement and the corporate powers that continued to pretty much set the terms. And the deal was that workers would have a piece of the improved productivity and improved standard of living and an elaborate system of employer-provided benefits in a private welfare state. And in return, we would abandon the sort of attempts to legislate those benefits and turn them into social benefits and social insurance and allow corporate powers to sort of maintain the commanding heights of the economy. So there was a real trade-off there. And then that was sort of really fed and strengthened by Cold War anti-communism right up into the 1960s. And that sort of set the terms for the kind of healthcare system that we live under. In the 60s, there were a few changes. The Medicare system basically made healthcare a right for everybody over 65 in this society. Medicaid made it a limited right for others, and then the final right that you have to health care in this society is the right to go to an emergency room and demand treatment and then refuse to pay the outrageous bill that you'll get a couple of months later. That's when you think about it, of all the ways to provide that right, that's the most inefficient and expensive and inhumane way to do it. So beginning in the 1980s, a lot of this whole deal started to fray that we had that provided health care. The growth of neoliberalism really attacked any kind of sense of security that working people, middle-class people would have in the society. And then the costs, as you all know, began to just spin out of control in the provision of health care, where costs were going up and continue to go up almost every year, 2, 3, 4 times faster than the general rate of inflation. But despite all of these tensions and pressures, the labor movement until very recently has hung on really tightly to this idea that our mission is to provide the best health care that we can for our members while they're working and into their retirement. And this has almost become an existential essence of what unions do for their members, and it's part of their self-identification, and it's really wrapped up in this whole employment-provided healthcare system. And just, in terms of thinking about, agents of change and possibilities to move forward, there's 2 different ways that unions have reached a negotiated solution to the healthcare problem of their members. The one is to demand that employers provide benefits for their members through some kind of employment-provided system, and that's pretty much a straight bargaining over cost, and you try to get as much as you can, and the employer tries to save as much as he can. The second way, and a more interesting way, is what's known as multi-employer plans, union-sponsored welfare funds. Some of these funds can be really, because they're dealing with the worker through the whole phases of their career and their life, and there's a continuation of coverage, they can be real agents for new ideas and new change. The Affordable Care Act adds all kinds of new stresses to the employer relationship and has really created a crisis in the labor movement. There was a sharp debate at this year's AFL-CIO convention. There's an understanding that employer-provided benefits, as we've lived for the last 50 years under them, are no longer sustainable, and there has to be something new. There has to be a change. And so this is a real moment of opportunity and real change within the labor movement. We've embraced the human rights model of defining what healthcare is about and defining standards and conditions for healthcare coverage. Somebody mentioned Vermont. That's sort of been the laboratory for some of this discussion and innovation around healthcare policy based on a human rights approach rather than a benefits-based approach. So this is really where we are today. So our vision is that healthcare is embedded as a right in a very different kind of a world of the future, where it's part of a broad system of social insurance and social respect for the lives of people, that it's integrated into the other causes of unhealthiness, like inequality and like environmental and occupational exposures to toxic and carcinogenic materials, and all of the other drivers of ill health in the society, that there's a very broad and integrated approach to health care. So just in summary, I would just say that we have one kind of broad concern and one hope from this movement of that you all are launching in this conference. Our concern is that the trope of affordability and overuse and waste will be appropriated by the sort of neoliberal austerity forces and used as a hammer to cut back benefits for those least able to maintain access to health care. And you see that happening in a multitude of ways. And that's a danger, and that's why I think you will find that groups like labor and community organizations tend to stay a little bit distant from this movement. But on the other hand, our hope is that this vision that you are beginning to embrace here, can become a vision of patient-centered, integrated, and informed care, and that it can help mobilize a real transformative movement that puts human needs and human values at the center of the healthcare system. And I think if you change healthcare, you change so many other things in the society, and you build a more humane society. So let's hope that we move in that direction. Thank you.
Mark, wonderful. Wonderful, Mark. Dick, some thoughts about the future?
This is a wonderful meeting, and I've been struck by how the things that we've been talking about are going on at so much larger levels all through our society. I'll tell a little personal story and then go forward with it. My dad was born in Hudson, Massachusetts, went off to be a fighter pilot in the South Pacific, survived that, came back. Within 3 years, had 3 little babies, and we were living in Hudson, Massachusetts. He was a strong young man, could do 100 push-ups at a time. And he was dead in 2 days of August 1949 of polio. And it put my mother in poverty, and we moved back to where her family lived in Newark, New Jersey, and I grew up there. And I tell this story because I ended up a pediatrician, probably because of those life experiences. I ended up in public health and worked for CDC, and actually was desperate to work on smallpox eradication and polio eradication and other things. But growing up in New Jersey, I ended up obsessed with the environment. And people joke about New Jersey, but you don't live there without being aware of just the chemical assault that occurred in places like this. And the workers got the worst of it, but the general public got an awful lot of it. I wanted to do something with this, and I went off to do my master's. I'm from Newark, New Jersey. I got into UCSF, so this was a tough decision about where to go to medical school, right? Maria, California, and I live out there, and became obsessed with farm worker health and pesticides, and quickly learned that we were using it's $30 billion worth of pesticides on all the food grown in California. And the people most exposed, literally 1,000 times more than the general consumer eating fruits and vegetables, were the workers. And there was no means to really track who was getting sick. There was no health care. The kids were doing badly in school. And it didn't take long to realize it was the system that was broken, and I could do little medical stuff for them, but how do we reform the pesticide system, the agricultural system, other kind of support systems for the workers? Worked on that, and in '94 went to CDC, and I became the director of the National Center for Environmental Health. And it was a much bigger, harder job than I ever imagined. But I realized, every time I'm thinking, since World War II, we have created things that we've put into our air that stay in people's bodies, that get into breast milk, that get into our babies, and will stay in our progeny for generations, and in the animal world. And some of them are gender bending, they have a whole series of impacts as well. What we have put in our water, if you look at water pollution in the US, yes, we worry about microbes, but it's caffeine, ibuprofen, female hormones, and a series of other things very quickly appear in what's in our water. When I think about our food and how we have created a disaster with food, the state of Iowa cannot grow enough food to feed itself for 3 days. It's 98% under corn and soy, all of it glyphosate, that is Roundup resistant. Every child in the Midwest now drinks a certain amount of glyphosate and also nitrates from the fertilizers that have gotten to the groundwater and gotten into the Mississippi River Basin. And 7,000 square miles of wonderful fish-bearing Gulf of Mexico is dead every single year from what we're doing. And by the way, $14 billion of tax dollars are used every year to grow all this corn and soy. And guess where else it ends up? In the very fact that the stuff that's bad for us in the supermarket is half as expensive as it was in 1980, and the stuff that's good for us is twice as expensive. And I have the data, I can vouch for this. So I go off to CDC, and pretty soon we're dealing with the radiation threats. And the industrial machine of the United States ended up making far more nuclear weapons. Maybe you could argue we don't need any at all, but we had far more than any conceivable level of defense could have predicted. I didn't know we had made enough chemical weapons to destroy every mammal on the face of the earth. The money was just coming in, and Union Carbide and the rest of them were just making these. Anniston, Alabama, one of the 6 sites where we're keeping chemical weapons, had enough to kill all the mammals on the face of the earth. So we CDC had oversight of that, and then I was weighed with all these cheerful thoughts with the issue of climate change and how
It's bad enough.
in my lifetime we went from 300 parts per million of CO2 in the atmosphere to 400 parts per million. We have more energy, more moisture in the atmosphere, and no one ever saw a Category 6 storm. Well, it didn't even exist until what hit the Philippines 2 weeks ago. So I think the trajectory of where we're going is desperately, desperately bad, and it's been due to the whole drive that everything we do has got to be generating short-term economic benefits. And as I looked at the health issues and the lack of fitness and the obesity issues, again I come to the idea that we have made our children our enemy, and that the United States of America is guilty of generational child abuse. And that's strong words, but I absolutely believe that that's what we are doing. We're doing it economically and medical care as well. So I was delighted to find and meet the folks at the New America Institute. I gave a talk there, met Patrick Doherty, who was and is a brilliant young man thinking about U.S. overseas strategy. And Puck Mickleby, who was the advisor to the heads of the Pentagon about where the strategy of the U.S. ought to be from a military standpoint. Pentagon's taking 18% of all the federal budget. Medical care is taking 19% of all the money in the United States. And we're on a trajectory of self-destruction. How do we come up with a new strategy about where we go? 6 months ago, I was offered a chance to live in Franklin Roosevelt's house. And I'm up in the servants' quarters on the 6th floor on East 65th Street. But I got to think about whatever I wanted to think about and to write. And we organized an event in the Roosevelt Mansion in New York on a grand strategy for the U.S. And Patrick spoke about our political posture and how we begin to ally with the power and the needs of other countries rather than to be competing with them, particularly in the face of depleting resources, in the face of 300 million new middle class demanding resources around the world, the global parity that we have to look at. Puck, the Marine Corps fighter pilot, talked about the fact that we need to be spending a whole lot more in education. We don't need the Joint Strike Fighter, and he went to great length about how we go from 1950 thinking about military protection to 21st century. And I was talking about the need to rebuild every community in America that is friendly, not just to cars, but to old people, to young people, to disabled people, that people can meet their life needs without being held hostage to a car. And you can imagine living in Los Angeles, this is a palpable reality for me. And I think moving beyond 20th century thinking, where we are so owned by our need to consume things. Our bodies have gotten bigger, our cars have gotten bigger, our houses have gotten bigger, our commute times have gotten bigger. Everything's going in the wrong way. And how do we move back to an environment that gives us physical vitality, that gives us connectedness with each other? So I'm over time, but my vision for the ideal medical system. So I was state health officer in California for a couple years. And I visited a lot of counties and states and visited Humboldt del Norte, the Potawatomi Indian Reservation. And the California Endowment helped them build a hospital healthcare center for the Native Americans there. It had 7 sites where various kinds of medical care would be given, and a central courtyard, which was a healing area. By the way, the physicians were the ones that complained most about what a waste of money it was to put the healing garden in the middle of the hospital. I visited the place and was struck by how many physicians were sitting in the healing garden, and was struck at just the wonderful feeling of the place. But outside there were these sweat lodges. And I thought, sweat lodges, what do you got those for? So, well, we have a lot of problems with substance abuse in these reservations. And a 45-year-old man is not going to go to psychotherapy in the traditional white, but they'll go to the sweat lodge and they'll talk about a lot of things during that time. And they had 4 acres of organic gardens. So I think getting the services that are culturally appropriate closer to where people live is where we need to be going.
Wonderful. So, rebuilding every community around their cultural needs in a sustainable way to change the trajectory of our future, so we're not stealing from our kids. What a wonderful vision.
You're pretty communist, huh?
Yeah. Joanne.
All right. Well, with Elliot's permission, I'm going to stand up because I have too much energy to sit down with this set of ideas.
I've never been able to stop you from doing anything in the past, Joanne.
And I'm going to build on Richard's idea of community, but we'll come around to that in a minute. First, let me make sure everybody's really awake. How many people here hope to grow old? Okay. How many expect to die? Easier question, right? How many would like to live to be at least 85 years old? Okay.
Maybe.
How many of you, keep your hands up now, keep your hands up, everybody, want to stay at 85. How many of you have a plan for at least 3 years of dementia? Okay, this is our problem. We are going to double the number of people who live to old age in the next 20 years. And it is changing a whole lot of things about how we live, and we aren't noticing that. We aren't kind of catching up with it. Can anyone name a television character or a movie in which the star character is someone who is in the frail period of life?
Nebraska.
Yeah, okay, you can get 1, okay, 2.
That was pretty good.
3. And, okay, there are a few, but think how rare they are and how few examples we have of how to live well in what most of us will get. Most of us are old enough that we can pretty much expect to make it well into our 80s. And once you are that old, you are really likely to die in a series of small events that end up with a substantial period of disability. We now average 3 years of self-care disability in the last period of life. Now, some people, of course, will be perfectly fine up until they have their massive stroke, and they'll die over 2 weeks, and their families will say, boy, didn't we get off easy. And others will have a terrible stroke and live 10 or 15 years. Even if with the stroke at 85 or 90, they will live a long, long time. And we have not redesigned our society to expect a substantial period of disability at the end of life. And this is not quite the grand vision and the grand challenge that Richard lays out, but it is a small piece, and I've been working on it for so long, and I can finally see a way through, all the way through. We could actually solve this problem in the United States within the next decade just by generating the will and trying it out, and that's what we need to do. Now, those of you from other countries may find some of our problems quaint, but we, nevertheless, have these serious problems. So the first thing is we don't notice this period of life. We don't talk about the period of frailty. We don't set aside a different kind of care system, and we really must. When I was a trainee in medicine in the early 70s, we didn't have very many people who lived into this period of life, and they could just sort of be on the fringes. Now most of us will be there, and we will spend half of our lifetime health care costs in that period of life. We don't think that's the case, but that's because we don't add in long-term care costs. The costs of taking a family member out of the workforce, the costs of being in a nursing home for a year or two, the enormous costs of having somebody having to feed you every day, having to change you, having to move you. Those are real costs. And right now, we not only don't pay those costs well, we systematically make the workers in that industry not even real workers. They finally have come under the Fair Labor Standards Law just in the last month. So we have set up 3 million, mostly women, to come to their own old age with no savings and never having had reliable benefits. What kind of a world is this? If we are going to redesign care to take care of our own old age, we are going to have to make real jobs for that part of the workforce. So we need to see this part of life as different. It is not the end of life that we saw in 1970. It is a very different last phase of life. It goes for a variable period of time. The person is in their usual state of ill health just a few weeks before they die. Yes, they're living with 16 medications and 17 diagnoses and various disabilities, but there's no reason to know they're dying this month until they also have the pneumonia or also have the stroke or eat a pretzel and tip themselves into failure and go on and die. And so it's little things that actually precipitate the dying. It's not a predictable course. The second thing that you need to understand with this course is that we must have individualized care plans. Someone was mentioning that yesterday, Katie Butler, about the fact that people come to old age in very different ways, and they really need individualized care plans. You need to understand this person and do what they need to have done with their resources, their family, and build a care plan. Once you have a care plan, you could actually plan for a community, a terribly clever idea. If you had, for those communities, all the care plans you needed for all of the frail elders, you could know where Meals on Wheels needed to be. You could know how many home health aides you needed. You would have a tool for management. You'd be able to build a dashboard. And you could return control to the community. Now, along the way, you need to fix medical care, which has become inimical to well-being of frail elders, and we've talked a lot about that. And we also need to bring in all those social and environmental services. How is it we allow anybody to build an apartment building that isn't already universal design? We're going to have 20% of the population needing disability adaptation. Why do we ever allow a shower to be built without a handrail? This is just inconceivable. But the trick here is that we could return management control to the community. People become quite tied to their community at this phase of their life. You can't go somewhere else for a second opinion on spoon feeding. It's got to happen where you live at least 3 or 4 times a day, all the time, over and over again. And if you don't have somebody skilled in spoon feeding in your community, you don't have it. If you don't have a way to get Meals on Wheels, we have communities in the United States with 6-week waits on Meals on Wheels for people leaving the hospital. How can we tolerate that? We cut 12 million meals out in the sequester. And where are we marching? Where are we angry about this? We have to notice that it's the resources of your community that determine how you can live when you are old and frail, and thereby return some degree of monitoring and control back to that community. Now, that doesn't mean that it has to be a single payer. It doesn't mean it has to be owned by one system. But it does mean there has to be some sort of coalition and cooperation that makes it possible for every community to step forward and be reliable in the servicing and supporting of people who are coming to the end of life with frailty. This is one of our big challenges, but the really clever thing right now is we have so much waste on the medical care side that in general, if we could harvest that waste, we would have enough to do these good things. And not only that, we have a tool to do it. We could use the thinking behind the accountable care organizations in the United States and build shared savings models in which what you save on the medical care side can support those social services and the management. What do you think? Could you do it in your community for people living here in the United States? Now, I know people in other countries already have this. There's no other country that doesn't have a local layer of management for the care system. We don't. We think that somehow Sacramento and Baltimore are going to be able to manage every community in California. Can't be done. You're going to have to think, where are the communities that could take the vanguard and figure out how to do this right? And then we could at least solve this little piece of the big puzzle.
Some wonderful themes we will come back to, although I think Joanna's hit the nail on the head with will and the question of insufficient outrage.
We were asked to talk about how we saw the healthcare system developing, and realizing that covers a very wide span, I chose one particular element. It has to do with infrastructure. You come to understand that that's probably the key role of leadership, is building infrastructure. It provides water in which the fish swim. It's usually unremarked. A thankless task at one level. It's the tracks on which the trains run. But I wanted to talk about one element of infrastructure that's advancing rapidly, and I personally believe is going to have a larger impact than any other single thing that we'll do, as it quietly happens in background. And I have two framing issues around it. The first has to do with an interesting little paper published in British Medical Journal in 2003. I have to read the title to you. Parachute used to prevent death and major trauma related to gravitational challenge. Systematic review of randomized controlled trials. Their systematic reviews find that there are no trials of parachute use. On the other hand, parachutes meet all of the criteria for demanding a randomized controlled trial. Widely used to prevent death and major injury after gravitational challenge, associated with adverse effects. Occasionally the parachute kills people. And there are documented instances where people have fallen a great distance and not died. And they point out that the purported benefits of parachutes could be a healthy cohort effect. They go on to propose a randomized controlled trial with a crossover design, for those of you who are into trials, and then suggest that those who demand trials for every question should be the first to volunteer.
Hear, hear.
Now, this is that typical dry British humor, and it's just delightful. The reason it's funny has to do with effect size. Some things, the causal relationships are so visible to the naked eye that you don't need a trial to see them. We're after causal relationships, if this, then that, in a reliable sort of a way. Unfortunately, the vast majority of human experience, that's not true. The naked eye cannot see the effects. That's particularly true in healthcare, as in so many other areas of medicine. So one framing factor to think about. The second framing factor, twice at the Institute of Medicine, we studied something called transparency. Both times we came to a particular definition of that term. It's the idea that a patient in a healthcare setting usually in consultation with a trusted advisor. That turns out to be the primary role of a physician or a nurse. Has sufficient information about their treatment choices and their likely outcomes that they can make wise decisions. Doesn't have to be a perfect system, just has to be adequate to that purpose. This idea of transparency, true transparency, knowing the end from the beginning, being able to predict those causal linkages as it applies to me. Well, that brings us to the thing that I think will change more than anything. In one sense, I need to distinguish between transparency and accountability. What I've discovered in years of research, at least within Intermountain, for my clinical teams, I don't need to improve their work ethic. I don't need to improve their dedication to patients. It would be hard to imagine doing that, frankly. It's already so high. I don't need to really tell them what to do. I need to make it transparent so that they can see the linkage. Today, that's not true. It's mostly based upon what we call subjective recall, in my experience, where we have a solid body of evidence that is inherently unreliable. We'll misestimate measurable parameters by 20 to 50%. We'll tend to be very, very highly biased. We believe we're doing good when we're actively doing harms. So one example, we're responsible as a system for almost 60,000 type 2 diabetics. We produced a series of tools to make diabetes care transparent. It was associated for complex diabetics, so type 2 diabetes mellitus, at least 3 significant comorbidities. 2-year hospitalization rates fell from 39% to 29%. 2-year mortality fell by about 6 percentage points. Major cost savings associated with clearly better clinical outcomes. It's the most fascinating thing. I use this as a teaching example. I show the reports that we sent out. One of them is comparative outcomes, how you compare to your peers. It turns out, though, that almost all of the impact in that dramatic change came from making it easier to do it right, not comparing. The comparison data had almost no impact. The financial incentives had almost no impact. Making it transparent had massive impact. We studied cardiac testing. 3 main choices for a cardiac stress test: a plain stress test, what's called stress echo, or a nuclear scan, system-IBI. Massive differences in cost. Again, we made it transparent. A set of indications, scientific indications for why you'd choose one of these tests. Just ask physicians to list their indication when they did it. We were actually trying to remove the burden of pre-authorization, and it did fairly dramatically, associated with a dramatic shift in testing rates, and particularly a drop of those very expensive nuclear scans, shifting into stress echo, which has a much higher information content for the money that you spend. I've got 100 examples like that. It's associated with significant increases in mortality rates within our system. I can document more than 1,000 lives per year by making it transparent. So what am I talking about? The healthcare system of the future. I see rapid and dramatic advances in underlying information technology that are associated with those sorts of factors, and it extends outward from that. Our current systems are grossly inadequate compared to that identified need. This will be one of those things that change the water in which we swim. And to complement some of the other comments that other people have listed. And so with that, Elliot, back to you.
Brent, that was... There's a wonderful connection between what Joanne was talking about the need for advanced care planning and care plans, and having those available everywhere so that people actually can use them. Patrick.
It's really such an honor and privilege to be here with all of you, to be with this panel. I'd like to frame a couple comments around purpose and power and the relationship between the two of them. Walking in today, Vikas found me and he said, no need for heavy lifting, just speak your truth. So here goes. I was a medical student when someone told me something that really changed my life. I was sitting in an audience of about 100 students over at the Harvard School of Public Health in the Kresge Auditorium, and the speaker was Jim Kim, who, as many of you know, is the co-founder of Partners in Health. He's the current president of the World Bank. And at one moment in his talk, he looked up, and I swear he looked at all 100 of us right in the eyes, though of course that's not possible. And he said this. He said, optimism is a moral choice. Optimism is a moral choice, but good intentions are not enough. We have to learn how to deliver. So when Partners in Health began their work in Haiti, they had no reason to believe that they would be successful, that they would change our understanding globally of the dignity in healthcare that's deliverable to the poorest people in the most difficult conditions, that they would inspire a generation to follow in their footsteps. They had no idea that that would happen. But they did know that they had to do it, that it was the right thing to do, that they would walk into that jungle with a commitment to make the road by walking. And by doing so, they could stick to it, and they succeeded. And what it meant for me to hear those words, optimism is a moral choice, it told me that there was a possibility that in the future, my life might be undivided, that what I did and what was most meaningful to me might be one, that I could work alongside colleagues who felt that way, who were animated by that common cause, and that my work might one day be meaningful. And those words carried me through medical school, residency. I went to work for Partners in Health in Rwanda when I finished training. I learned about health systems and helping them work better for vulnerable communities under difficult conditions. I watched leaders make really difficult decisions, painful choices with limited resources about how and where to spend. But they did so factoring hope and dignity always. People and the impact of these choices on their lives was always central in the room. I had the opportunity to start a residency program at Mass General Hospital called the Global Primary Care Program, which tried to teach these lessons I had learned in Rwanda to a generation that was hungry for them, and help them see that these were universal lessons. These are principles that didn't apply just in Rwanda, but could be applicable here, that they might actually be part of the key to our being able to move lessons and optimism between settings, anchoring this generation. When we put this residency out in the National Residency Matching Program for the first time with really no chance to market it, no chance to really do all the invitations that we should have, we were astounded to find that more than 600 applicants applied from 86 countries for just 2 spots, making it one of the most competitive residencies in the country in its first year. And what they said sounded a lot like what I felt in my own heart, that this is not about a place in the world. This is about health equity. It's about social justice. It's about health as a human right. It's about broken health systems. It's about a way to make that better. And they wanted that training. They wanted to do that. And I think that was just the tip of the iceberg. What I really wanted to communicate is that I think there is a rising tide of optimism, pragmatic optimism that wants to deliver and not just have good intentions. And it's all around us. And there is a movement already. If the need to challenge unfettered capitalism with public demand and public debate, as Diane Meyer invited us to consider, is there. If the dream of imagining the profession speaking with one voice, as Don Bowick invited us to consider, is there, then we need to not only build a movement, we need to make common cause with an existing movement that has been underway for over a decade. Many of you are aware of what that movement has achieved, but I'll just mention 2 of the outcomes that really stick in my mind. So today, in pretty much any country in the world, and at a price that the poorest people can afford, life-saving treatment for HIV is available. Almost anyone could get that treatment in any country of the world. Nearly every medical school in the US has been responding to this surge in demand. The number of global health programs has tripled over a 3 to 4 year period. Programs either in place or in development. This demand is driving a transformation across medical education. There's a disconnect between what is visible, I think, for those of us working on the right care movement domestically and globally. And we don't need to look for that army there amongst us. But the question is, how do we bring them together? when I was in rural Liberia with a colleague and we were implementing a mental health program deep in a rainforest about 12 hours from the nearest city, we would often reflect on what it would take to make this vision of just and fair care possible across the country. And we would tell ourselves that we need to master 2 languages to affect that kind of change: the language of love and the language of power. And we really saw those as 2 separate languages, but it was later when I was sitting in a classroom in the Kennedy School listening to Marshall Gann's talk about the intelligence behind his organizing strategy. And he defined power this way. He said, "Power is when your need for my resources is greater than my need for your resources." An extreme example of that, if your need not to be embarrassed on national TV as a leader of a government is greater than my need for food and life itself, I can starve myself in a hunger strike on a national TV and make you act. A less extreme example, just down the street again at Harvard Medical School, there was a moment where the dean of our medical school defunded a small and relatively unknown primary care working group. But someone named Andrew Morse Singer, who had his background in community organizing in the gay and lesbian rights movement, recognized the opportunity. And he galvanized a movement around this, a series of town halls, an uproar across the primary care community, and a generous and forward-looking donor came forward, and a $35 million Center for Primary Care was founded at Harvard Medical School, which will possibly be the lasting legacy of this dean when that may not have been his initial intention. And to his to his great credit, I think he has embraced it, he has really seen the possibility, and has been behind it every step of the way. But this is how the ripple begins, I think. The language of love and the language of power may not be separate languages, but the same. They require us to make a promise to the generation that wants to believe that optimism is a moral choice, to help them believe that that can be their future, that they can work meaningfully alongside us here in the U.S., that we can engage the leadership and the structures and the existing bodies that are already there around us for global health, and make it about global health truly, where we are on the globe and these problems are universal. And perhaps the biggest opportunity in global health today is to take this time-limited window that we have with the Affordable Care Act, this modest financial reform, and create tremendous, deep, and lasting transformation in the delivery system, in what we think of as care itself, who it engages, who is driving that care, which parts of our sectors it covers, and that will ripple forward in history, that will ripple out to the world, and that will change the nature of health all around the world. So optimism, we should harness it. Thank you.
Wow. What a wonderful set of varied and really important perspectives. We have another hour and a half to talk about this. We have 15 minutes before the break, or maybe it's 10 or 5, who knows. I would love to encourage people, everyone in the audience, to think about your vision of what care might be like in 25 years and be able to capture it in a brief comment so that we get as many different elements of that vision formulated as possible. We've heard some wonderful perspectives here. Try to build on them, not necessarily replace them or argue with them or extend them. Try to add substantially to the conversation. So why don't we start over here and introduce yourself so that everyone knows who you are, including me.
Tom Workman from the Center for Patient and Consumer Engagement at American Institutes for Research. I'm so struck listening to this panel in comparison to the close of Stanford's Medicine X conference this year, where futurists spoke in detail about the vision of the future that in 10 years we will see an 80% reduction in system-based medicine because patients who are now engaged through technology find each other and actually are able to share with technology many of the things that they're using medical systems for. In this extremely patient-centered or patient-centric vision, there seems to be a future vision where there's less division between the patient and the physician and even the clinic or the system, and much more a sense of citizens sharing resources together to keep healthy. I'm fascinated by that vision, and I'm fascinated by what role our truly empowering patients to play a much stronger partner position might be in creating this future vision.
Tom, great comment. I'm sure others will add to that. And there's a whole literature on facilitated networks and how they're one of the major business models that could actually emerge and disrupt everything the rest of us are doing in health systems. So taking a turn over here.
Hi, everyone. My name is Sana Shahimi. Hi, Dick. I'm with Prevention Institute. Just wanted to really quickly tell you a little bit about Prevention Institute. We're a national public health nonprofit. We are based out in Oakland, California, though I work in our DC office. And we're founded to focus exclusively on advancing primary prevention. You know, what do we do before people get sick and injured in the first place? What are the public policies that we need to put in place? What are the organizational practices that we need to change? And we know a lot about what works. We know how to get healthy, affordable foods to communities. We know how to prevent violence from happening in communities, you know, not through a law enforcement and incarceration perspective, but through a public health approach that builds the resiliency and strength of communities. We know how we should be designing our communities so that they're walkable and bikeable and we're not held hostage by our cars. You know, so we know how to do all of these things from a public health perspective, but what we lack really is, you know, political will to invest in these kinds of strategies. So from Prevention Institute's perspective, we see the vision as one in which our unit of analysis isn't just patients, but entire communities. And we're really looking at ways to allow entire communities to thrive for as long as possible, and where we're breaking down these arbitrary walls between healthcare and healthcare delivery and public health and public policy. So we're really looking at community-centered health homes and community-centered care. And I'd love to talk more with people about this during the break. I'm probably the only person wearing bright yellow pants, so you can easily recognize me. I wanted to put in one other plug, and I can share this with anyone who's interested. Our Chief Communications Officer launched last week a series, he's a journalist as well, in Forbes called Profiles in Innovation, where we are profiling healthcare leaders and healthcare innovators that are, through their work, are also addressing the community environment. So last week we profiled Dr. Robert Kahn from Cincinnati Children's and the work that they're doing around hotspotting around asthma, but also that looks at housing code enforcement. I think next week will be Jim Mangia in St. John's. Wonderful. And the work that they've done around healthy housing.
We will look at Forbes, and it resonates nicely with what Dick was talking about. Over to here, thanks.
Yes, I must say the most difficult thing about this conference is choosing which of the 1,000 comments or questions I want to use my moment here. But this question is directed particularly
Introducing yourself?
Mark. I'm sorry, I'm Carol Casella. I'm a physician and novelist from Seattle, Washington, and writer on medical issues. So Mark, talking about the single payer system, which I think so much of this conference has thought might be an answer to some of these problems, do you feel we'll be able to get enough public momentum behind a single payer system as long as businesses are still buying so much of our health care and so many of the people who have power and influence are therefore covered?
Great question. So what do you think?
A bunch.
What?
Well, I think fundamentally the this is a fight against corporate power, and I think that's why it's so difficult to achieve a single-payer system here. It's not a question of the policy solutions. You know, we've basically won the battle of ideas on single-payer. You can kind of get into the grass on some of that stuff in terms of system design. But really, you know, the problem is it's a fight against corporate power, that there's an entrenched system, for-profit Medicare system in this country that treats medicine as a commodity, and we want to treat it as a human right. And what we have to do is construct a movement strong enough to confront that corporate power. It's an organizing problem. It's not a policy problem. So, you know, and I think I think that there is a displaced hope that somehow you can convince corporate America that it's in their best interest to fight for single payer. It is in their best interest, but you won't convince them of that until after you won it. It's the same thing as financial regulation and a lot of these other attempts to regulate sort of unfettered capitalism. It's, you know, the pressure has to come from the outside, and you know, you make that change, and then the people on the inside will accommodate themselves to that change, and generally they'll thrive under it.
And there's one other theme that we probably ought to throw in there, which is the community notion that has already emerged, and the notion of positive deviance. That is, it may be that a few places around the country that do this actually shake up people's thinking, and maybe Vermont can make a difference that
absolutely.
way. So
I mean,
community by community, rather than, I sometimes get discouraged about Washington, D.C., but I don't know why that is. Go
Hi
ahead.
there. Stephen Hatch from the University of Massachusetts, also in a pink pastel here, so we're the colorful side of the aisle. Also, as a follow-up to this, I have a question for you, Mark. Although anybody on the panel can feel free to weigh in. It's about how you frame the terms of the debate. When you talk about single payer, this is actually much more of a, and I'm using this term in quotes, a left-wing solution. And it turns out that the law that we have, the Affordable Care Act, was originally conceived in the offices of the Heritage Foundation in the 1990s. And yet, when you look at mainstream media, this is not just merely Fox News who is screeching about the socialism of the Affordable Care Act, but if you watch Rachel Maddow at night, she is cheerleading the Affordable Care Act as the liberal solution, when in fact, from my point of view, it is a center-right solution, and which you can debate the merits of. The question is, do you feel that we have a situation of false equivalence, that if you have Republicans screaming that it's socialism, that by definition, if the Democrats are proposing it, they must be right, and that you have a similar false equivalence that you see in sort of debates over evolution, in which you say, well, there's evolution and there's creationism, we have to give equal airtime, and so there has to be this equivalent situation where we have to say, well, if the Democrats propose it, it therefore must be a left-wing / socialist solution when we live in a center-right country.
If you can say something very short, because I want to get one more voice in before I think the politics of this are playing out both nationally and locally, and we have to be thinking about both, but I'd love to hear your...
Yeah, I think you're right that the debate over the ACA is more about partisan politics rather than about kind of a broader perspective. But I also would point out, though, that when you get beyond the sort of left-right thinking, you know, 60-something% of people who identify with the Tea Party support Medicare as a fundamental system. You know, when they don't want to cut Social Security. So all of these kind of social insurance visions really don't split in the way that Fox News tries to split these issues. So if we can find a way to kind of enter that debate and seize those terms, I think
we are going to have to stop now. No more questions. We'll be back at the microphones after the break. I do want to encourage, again, people coming up to the microphones, you know, to think about what is it we want to see? What are we going to pull people toward? Less about what are the arguments about tactics and looking backwards. We will do that probably in the last half hour. One announcement before you go. Hey, hang on. People who have volunteered for the